Viewer contributions make local programming possible on WNIN. Become a member of WNIN with your contribution so we can continue to make this programming available. Visit WNIN.org and click on the donate button.
Thank you, Margaret. Good afternoon, everyone. I really appreciate the opportunity to be here and speak to you today. I want to thank our board members who are here and our entire board who supports us quite a bit, and the ideas and just everything that they do to continue to push us to make us better. That's what our goal is, to always strive to lead in public health here in Indiana. So thank you, board members, for being here today. And I want to just real briefly kind of talk about what we're going to hear from several members of our staff. I'm smart enough to know that I shouldn't be the one up here talking about this stuff. They're the subject matter experts, so the good news is you don't have to hear me drone on for the next 20 minutes. But we at the Vanderburgh County Health Department over the years have tried to look for ways to be more proactive in what we do in public health. Try to improve the health and within the children in our community, our pregnant moms, our families, to really bolster that start of life and to ensure that these families and these kids have the opportunities to improve their health, to expand their ability to learn when they get to that school age, and to find ways to then grow up in this community, hopefully stay here for long term, so that we again strengthen our community here in Evansville and Vanderburgh County and even Southwest Indiana. So we got 3 different programs we want to highlight. We're going to talk about our immunization program and our pre-to-3 program, which some of you might have we've discussed that here at Rotary in the past, but then also our lead program, which has really skyrocketed because some new staff members and some money that we've received from the state as far as additional funding to expand our efforts in public health. So to start off, I'm going to ask Erin Reese to come up. She is the lead immunization program. She's a public health nurse, and she's been with the health department for nearly 15 years. So she is definitely a subject matter expert in the world of immunization. So I'd like to invite her to speak first.
So I have been asked to just give you guys a little bit of an update on immunizations in Vanderburgh County and what that looks like now. So I want to start off with just a little bit of kind of where we are. So before COVID, everything I feel like is in a before COVID and an after COVID world, especially as far as immunization. So before COVID, we were well above the state average in immunization coverage, 79%. We were working to get, of course, to higher rates. But the first year of COVID, we saw a significant drop that we were never really able to come back from. So as of December of last year, our immunization rates in the county had dropped to 71.7, which is a pretty significant drop. We also started looking at some of our other age groups, and we noticed that they were below what we called our herd immunity thresholds. Those are the thresholds where if we get vaccination rates high enough, it can prevent outbreaks of those diseases. So in a lot of our age groups, we're under those thresholds. So it just really shows the need for why we need to work on immunization coverage. Our next age group is the 11 and 12 and the 13 to 18-year-olds. Those are our school age kids, and those actually stayed pretty steady during the pandemics. We had some things in place that we were already doing to meet barriers for those age groups. So I think that really helped during the pandemic keep those rates fairly stable. So in 2020, next one. So last summer, 2024, I told the board this a couple of months ago. I felt like I was just spinning my wheels, just trying to figure out ways to get the immunization rates up. So we actually were able to use some grant funds and implement a survey countywide. It wasn't anything super fancy, just trying to get an idea of what people are experiencing barrier-wise, what people are experiencing perceptions-wise about vaccines, and we were able to share some of that with our local providers to help them out. And then we noticed that our biggest barriers were noted in the 47710, 47711, and 47714, which is not usually news. Those are a lot of times our zip codes that experience a lot of barriers. We did notice that school-age children and young adults were the ones experiencing some other significant barriers to accessing vaccine services. Biggest barriers noted were finances, not knowing where to go, not having time, clinic hours weren't conducive, don't have a doctor is a big one. So those are barriers that we were identified in our survey that are affecting residents of Vanderburgh County. As far as what VCHD is doing, one of our biggest interventions that we have been able to accomplish since 2017 is the implementation of school-based immunization clinic. This is a process where the parents consent for us to go into the school and provide their child with a vaccination. The consent form's online, it's translated, it can also be done in paper if needed. This meets all of the barriers for a parent who's having transportation barrier, doesn't have a doctor, doesn't have insurance, can't get off work to take their kid. This pretty much meets all of those barriers in our school age population. Working with our partners at EVSC has been really great. We did some awareness a little bit more in the spring to make sure people knew that we were having school-based clinics, and we felt like they were really, really great. One of the things that we did notice when we pulled some data from our form is that over half of our kiddos that we're seeing at these school-based clinics don't even have a doctor. They don't even have a medical home to go to get vaccine. Even if they have insurance or Medicaid, a lot of them, they're not going to a provider or a medical home. So we're basically their only place they can be vaccinated at that time. And then we'll go to the next one. For adults, we have a mobile unit that is going out. We were actually able to use some grant funds and COVID funds and work some things together back in 21 and 22 and get that up and running. We have a staff member and a team that goes out and does immunizations 2 to 3 times a week. Right now, they focus really heavily on our homeless population. They also go into some other areas that are experiencing barriers. The other thing that we do is a reminder recall. So any kiddos that are seen at the health department and they're due for a vaccine, every month we run a report and it tells us, hey, this kid's due for a vaccine. We send them a postcard, we call them, we get a hold of them, and we try to get them back in for an appointment. We also reach out to every baby born in Vanderburgh County. We were sending them a book with like a board book about vaccines and some information about our services. We did have to kind of cut that down a little bit because of funding cuts. So we're not sending the board book anymore, but we are still sending the packet so they know where we are, who we are, and that we can give them vaccines even if they don't have insurance or a doctor, that kind of thing. Good news, we were able to get a lot of our local providers to join with us in the reminder recall, and we have seen a significant improvement in just 6 months. So in April, we saw an improvement to 74.6%. In June, we were up to 77.7%. So we are as high as we've been since that initial drop in COVID. And there's, yes, makes me feel better. And we are going in the right direction. And I know a lot of our providers are seeing the fruits of their labor as well as ours in trying to get kids in for immunization. So things are working. We're just going to keep trying to go in the right direction. However, with everything else, there's been funding cuts. So in 2015 was the first time that the Vanderburgh County Health Department applied for an immunization grant. And between 2015 and 2024, we had approximately $1.5 million of funding. And that doesn't include all of the extra COVID pandemic funding, just the immunization funding that was coming in. And then last year, we had about $500,000 that came in. All of that is cut as of 7/1/25. So that was federal grant money that was filtered through the states. So what that funded was 5 full-time positions, medical supplies, it funded awareness, it funded our online programs, all of our supplies that we use for reminder recall, the postcards, the postage, the packets, the books, the printing, all of that was covered by immunization funds that we no longer had and we can no longer apply for. What we need, our mobile unit uses what they call survival bags. It's something that just has some stuff in it that is helpful to the homeless population. It brings people to the bus. They can discuss vaccines. It's an incentive of sorts. And they do have an Amazon wish list so that people can purchase items that get sent to the health department. We also have some supply needs with reminder recall posters. And then with transportation, I know people use a Mets Micro, and that's kind of become a something else that was experiencing cuts. And then even some of our kiddos who can try to get a ride, get to us, they don't always have a car seat, so they can't always use some of the services that are for transportation. So that's kind of where we are needs-wise. And thank you for letting me speak.
Thank you, Erin. And I think we'll wait for questions at the end after all the presentations, and then we'll be happy to answer questions. The next two speakers I'd like to ask up is Carissa Schutz. She is our Director of Outreach, and she has kind of two stints with us. She started, and then she left us, and then she came back, totaling about 5 years. And Sophie French is our PRETA-3 program supervisor, and she's been with the program since its inception back in 2017. So, ladies. So I didn't say.
That's okay. I was a last minute addition. So I'm just going to kind of start us off. Sophie and I are both going to talk a little bit more about maternal child health, specifically during the prenatal period, after delivery, and up until the child is 3 years old. So I'm just going to kind of start us off talking a little bit about infant mortality in Vanderburgh County. So infant mortality is a measure of the number of infants who die before their first birthday, and that's a rate that's given per 1,000 live births. So on this graph, kind of what I mostly want to point out, the gold line is Vanderburgh County overall in general. So for 2023, our rate in Vanderburgh County was 8.4 per 1,000 live births for infant mortality. And then I want to point out the non-Hispanic black line, which is the dark blue line, how much higher that is than our overall rate and then our non-Hispanic white rate. So in Vanderburgh County, Black infants are actually about 2.5 times more likely to die before their first birthday than non-Hispanic white infants. And so just for a little perspective, because sometimes the rate can be a little hard to, like, what does that really mean? 8.4 per 1,000 live births. So for our rate in 2023 for Vanderburgh County overall, that equates to approximately 17 infants that died before their first birthday. Okay, so that's a kindergarten class in 2023 that didn't make it to their first birthday. And so just kind of setting the background for that, for Sophie to talk a little bit more about the PRETA-3 program, which was implemented and put into place to address infant mortality and also birth outcomes in general for maternal child's health that ultimately impact the infant mortality rates in our area. So I'll let Sophie talk about the program.
Yes, we're going to go back and forth for a minute. She's the data guru, so we make a good team. So the PRETA-3 program, we essentially take referrals on prenatal clients and infants under 90 days old, and then we support them in the home until the child is 3 years of age. We're a unique program in the way that every family is assigned a team that includes their home visitor that sees them weekly initially, and that's a community health worker, then also a registered nurse who's a CLC, and then a social worker, or as we like to refer to them as a client advocate. So that is a local model. It's not necessarily really seen anywhere else. And it really makes sure that everything is addressed. We've got everything covered from the clinical component to the social component. And then we use an evidence-based curriculum called the Growing Great Kids curriculum. And really, it's the home visitor that initiates that curriculum on a weekly basis. With that curriculum, we really focus strongly on positive parenting practices, along with things like coping strategies, budgeting, looking for employment, growth and development, bonding and attachment, which is a huge piece, and that begins prenatally. Some of our objectives are listed here, and I think we've kind of reviewed all of those, but we always have the goal of working towards self-sufficiency. So as the child gets older, we start to back out of the home more and more. So from age 2 to 3, we're only in the home monthly. Sometimes things come up and we have to jump back in and may see them for, a crisis situation weekly, bi-weekly, and then back out. But that is our ultimate goal. So I'll let you kind of touch on the graph. Oh, yeah. Do you want to?
I thought maybe you had more to say.
I have a lot to say. And when they told me I had 5 minutes, I was like, "Ooh, this is going to be really tough." So,
okay, I'm going to just kind of touch back a little bit on some of the data. So Sophie kind of talked about what does our program do, and so I'm going to talk about how that makes a difference. This is some data that was actually, we partnered with Purdue University, and they worked on a manuscript for us, kind of a research article that is being published, and this is some of the data that they found through that research project for our program. So one of the things that we are very proud of, this bar graph here on, I guess, your left, is about depression. And so we do screen for depression prenatally and postnatally, just to kind of measure how that's going. And normally you would see that a trend when you screen prenatally versus postpartum, it gets a little worse postpartum, right? You have a lot of life changes, a lot of things going on. And so we actually saw a statistically significant improvement in depression rates prenatally compared to postpartum through the extra support that's offered through the Pre to 3 program and having somebody there available for the families. And then in the middle section, this one is a little bit more about some of those social determinants of health, if you will. So food security, employment status, and housing stability. All also saw statistically significant improvement from intake into the program until they've had their last visit within the program. So through everything Sophie talked about, we're able to address a lot of these areas, which are kind of the foundation to be able to improve more of those clinical health outcomes related to maternal child health. And then lastly, we have the household smoking, also statistically significant improvement, which can impact birth outcomes, things like preterm delivery, low birth weight, and also just kind of the environment that the child grows up in, right? If they're smoking in the home and things of that nature. So we're very proud of all of those, very excited of our partnership with Purdue to have some of this research completed. One of the other things that we've more recently implemented is doing a screening tool. It's called the Healthy Families Parenting Inventory, and it's an evidence-based valid tool to measure change across several domains. And when you measure that change across those domains, it is an indicator that it can reduce the incidence of child abuse and neglect. So it's an evidence-based tool. It's shown to do that. And so we have preliminary data that was evaluated through Deal Consulting Group, and this is some of that information. So if you'll see, we actually improved in most domain areas from when they were initially assessed to when they were reassessed. So we're very proud of that. It is initial, preliminary, so we're waiting to get some more data to see how that continues. The only area we saw a little bit of a decrease in, which we did expect from the initial assessment until 6 months postpartum, is personal care. I mean, that first 6 months, that kind of goes to the wayside while you're figuring everything else out. So we're going to keep an eye on that one and see how it progresses as we continue doing these assessments for families. And then these are just some of the outcomes that we measure throughout the program in general. Some of the big ones, which are also measured countywide and statewide, would be the term deliveries, so births greater, 37 weeks or greater, the birth weight greater than 2,500 grams, breastfeeding initiation, are some of the big ones that are measured through the county. We measure them within our program and then also within the state. And then we also measure several other things that are more safety related, like the car seat and the safe sleep space acquisition, that help improve those outcomes down the line and improve the maternal child health outcomes and reduce the infant mortality.
And just to touch on a couple things that we are implementing that are new, we are involved with the EPN and do receive some funding. And so we're very much focused on early literacy and have received some grant funds so that all of our kiddos have books. That's part of parent-child bonding, that's part of language development. It's part of building those neural pathways, which are so important. And so it's a huge piece of ours, that kindergarten readiness piece. Another thing we've implemented and already seen a lot of success from is the Cuff Kit program. The Indiana Hospital Association gave us some blood pressure cuffs for monitoring where you can, attach it to the Bluetooth and the app. And that has been really more useful than what we realized with our moms that have a high risk or moderate risk for preeclampsia, just so that they can advocate for themselves, they can monitor that themselves. And I know just one nurse, she's given out 9, and we have had 2 moms that have gone in and delivered early because of when we reviewed those signs and symptoms and they were monitoring their blood pressure. So we're already seeing a success with that, and are also going to work with some other partners to try to keep that going, because those blood pressure cuffs are limited, and we have gone through the first round really, really quickly, actually. So that's a big success. There was one more. Oh, yeah. And then in September, we're going to be initiating a substance use screening as well, just to get, we feel like, further data on that as we build those relationships with families, just so we can make sure that we're utilizing all the resources and really, addressing all of the needs holistically. This is just a quote that we'll close with. This was one of our moms who did have a history of substance use before she came into the program. Our lab is here today, and they did refer her to our program. And she came and not thinking she would stick with it. She said, I'm going to give it a little bit of time, but really did not think she would like it, or anyone in her home or her business, she said. So they have graduated the program. So this slide is a little old. It's from 18 months, but just how she grew, and she became really an advocate for the program, and also used all the words: self-regulation, social emotional skills. She can spit out that information like she wrote a book on it. So we were really proud of her, but we're proud of all of our families that have had such great outcomes. So thank you for allowing us to be here.
Thanks, Carissa. Thanks, Sophie. All right, so final couple speakers here talk about our lead program. Our lab director, Tamara Teague, has been with the health department for about 7 years, and Joanna Beck is also a director. She's over the environmental division, and she's been with us for about 3.5 years, but I round up, so it's almost 5. So, ladies.
Hello. My name's Tamara Teague, and I'm the lab director at the Vanderburgh County Health Department, and want to thank you for the opportunity to come today. We're really trying to raise awareness and let everyone know that lead poisoning is still a problem in Vanderburgh County, and it's something that threatens the children in Vanderburgh County. So in our lead program, there are 2 sides to it. There's a clinical side, which is me, and then there's an environmental side, which is Joanna. Not just me, because I have a team of people that help me, and so does she. But we kind of lead these 2 teams. So the first thing we want to talk about today is testing. Testing with lead is so crucial because there is no known safe level of lead in a child's blood. Even a very low level of lead can cause significant irreversible damage to a child's development and well-being. And one of those key words there is irreversible. If a child is lead poisoned, the damage is permanent, and it's not something they can come back from. So it makes things very difficult. Reasons why lead testing is essential. The one reason is children are very vulnerable. Their bodies are very vulnerable while their brains are developing in their bodies. And they also have a tendency for hand-to-mouth activity. So if they're living in a home where there's lead dust, or in a yard where there's lead in the soil, and they put hands in their mouth, their toys are in the floor or in the yard, and they put their hands in their mouth, that can create a situation for them. Lead is an invisible threat. It's an insidious toxin that's often found in the environment, especially in older homes that were built before 1978. It's important to remember that approximately 70% of the homes in Vanderburgh County were built before 1978. So there's no symptoms. Testing is the only indicator. Children that are lead poisoned are not going to present ill to their parents. It's just something that they need to be screened for. There are codes in Indiana that say that children should be tested at age 1 and age 2, and it's very important that parents follow that mandate. Lead poisoning can cause irreversible damage, such as neurodevelopmental issues, such as reduced IQ, learning disabilities, behavioral problems. It can cause slow growth, speech and hearing problems. Very high levels can even cause seizures, coma, and death. In our program, we try to align with the health department overall mission. We try to prevent lead poisoning by offering testing. We offer testing to children under the age of 7 years old, because that's when it's very impactful if children become lead poisoned if they're under 7 years old. So we offer testing to them, as well as pregnant and breastfeeding adults. If a woman is lead poisoned as a child, when she becomes pregnant, that lead can leach back out of her bones. It can cross the placenta whenever she's pregnant, and it can also be found in her breast milk if she chooses to breastfeed. So we offer in-house capillary screenings with same-day results, and we can also perform venous draws for confirmatory testing. We promote education and awareness at community outreach events, and we do also go into physicians' offices to make sure that they understand the necessity of meeting those mandated requirements for testing, and then making sure that they understand how to report those levels to the state so that it's documented that we're meeting the mark that we need to meet with our testing in our county. We offer protection. We offer case management and risk assessment on homes of children with elevated levels. Joanna will be speaking to you about that. And then we also offer remediation services on homes with lead hazards. And once again, Joanna, that's her division, so she'll talk about that. We do partner with many community partners. One that we have a very strong partnership with is Cape Head Start. In the lab, we actually go in at least once a year, sometimes 2 and 3 times. CAPE can identify what children are in that program that need to be lead tested, and then we actually go into the school and do that lead testing with parent permission, consent, and get that testing done at the school. As Sophie and Erin talked about, and Carissa, we do run across barriers with the population of clients that we serve, and we are working hard to try to meet people where they are. Some ways that our program does that is offering translation services. Currently, we offer translated documented materials. We also work with translation services to be able to conduct appointments with clients that don't speak English over an iPad. And then we also offer over-the-phone interpreting so that we can schedule appointments with clients that don't speak English. Transportation services. We have a lot of clients that have trouble getting to the health department, so we do try to partner them with some METS microservices. With HFI funding, we've been able to hire a full-time phlebotomist, which has freed that staff member up to actually go into homes with maybe our pre to three nurses or their advocates and draw blood in the home and be able to test their child's blood for lead. We try to combine services at the health department. If a child has got a WIC appointment and we see that they're in need of lead testing, we try to combine those appointments or combine their pre to 3 or their immunization appointment so that it's kind of a one-stop shop for these parents. They can come in one time and get lead testing done as well as their other appointments. So I'm not going to go into all the graphs, but we've really been trying to track what we do to monitor our success and look at areas where we need to improve. We found out that last year at the health department, we tested a total of 721, or we actually got 721 lead tests completed. The predominance of our clients last year were children, 84%. With 47% being between the ages of 1 and 2, which is great. Those are the target ages that we want children to be tested at. And about 59% of our clients last year did identify as being white. 89% of our clients last year needed capillary screenings, with 15% coming to us for follow-up care. 96% of our clients stated they either received Medicaid or they were uninsured, which is not a problem for us. We will test whether you have insurance or don't have insurance, if you're Medicaid or even if you have private insurance. 89% said that they did have a primary care provider, and 63 reported that they were receiving WIC benefits. Okay, so I'm now going to turn it over to Joanna, and she's going to talk to you about case management. Okay.
Thank you. So as Tamara said, my division, we handle the case management and the risk assessments of the home. So when a child has been identified as having an elevated blood lead level, we will go into the home and perform a full risk assessment where we do dust swipes. We have an XRF machine where we can test lead paint right on the spot. We send that off to the lab and we see what we're dealing with. As you can see from the slide, between 2022 and 2025, we've done about 70 risk assessments in Vanderburgh County, and predominantly the hazards that we see are coming from peeling and chipping paint on porches, sometimes trim in the home, doors, and windowsills. Most of the children who have an elevated blood lead level, they're a range, and predominantly what we see is between 5 and 9.9. And we work directly with physicians' offices and providers to try to help manage that care and see what we can do. And most of the children that we're seeing are seen by St. Vincent Extension, St. Vincent offices. So again, a lot of graphs, but most of the children who have elevated levels are between the ages of 2 and 4. Most have identified as white. Most of them are English speaking. Again, we do offer those translation services. When we go into the home, we can take that with us and do a complete risk assessment with a live translator right there, which has been extremely helpful. And one of the things that I really want to hone in on is 82% don't own their home. That's a barrier that we really, really face. These residents are scared. They don't want to let us into their home sometimes for fear that they might be evicted by their landlord. So we really try to smooth that pathway between us and the landlord. You know, it doesn't have to be scary. We're here to help. But at the end of the day, too, making sure that that property management group or that landlord understands that they have to fix that property, even if they do decide to evict our patients. So currently we have 32 confirmed cases. That's over 5. We are providing active case management. We've been in the home, we've conducted risk assessments. Sometimes we might even have to go to their daycare. Any place where a child is spending more than 6 hours a week, we're going to want to conduct a risk assessment there. We have 14 that are anticipatory. Maybe they've only had one test. We might be waiting on them. We're just really watching them to see if they go up. We have 2 that aren't technically a case, but again, our team is pretty involved. They might live in a really old home. We've seen hazards. Their level might be low, but we're still really watching them. And then we have 16 that we're waiting on a confirmatory level for. So I kind of like to talk about success stories as well. We had a child come to us at the health department with a dangerously high level. It was in the 30s. We did a risk assessment at the home. We didn't find any hazards, nothing. We did a risk assessment at the daycare. We conducted interviews. We could not find where this child was getting lead poisoned. And thankfully, due to some funding, we were able to send a couple of my staff members to a national conference where they brought back this technology, basically kind of like luminol. You sprayed it on surfaces, and when you shined a black light, it would fluoresce. So you can kind of see that in the photo. And we went back to the house. We sprayed toys, we sprayed walls, and we found it in a closet trim. And then really it kind of came to light after we did more interviews with the family. Their sibling was peeling the paint in that particular room and then feeding it to the patient. So it's been really good, and it's important for us to keep having funding so that we can keep finding these new technologies. And other growths that we've experienced, we have a HEPA vacuum loan program. We have 2 HEPA vacuums at the health department that landlords or property owners or even anybody can rent. It doesn't cost. We just ask you to fill out a form, and that filters that debris and dust when you're renovating down to the micron level it needs to be. You can't just vacuum it up. It'll go back out into the air and cause more issues. So we've been happy that we can have that. We have been able to renovate the lab to provide a full waiting room and a phlebotomy room. And probably, like Tamara was talking about, one of the biggest successes we've had is hiring the full-time phlebotomist that has increased our testing rates over 100%.
Again, thank you all for inviting us here today. We appreciate the opportunity to speak to you and share a little bit about the Vanderburgh County Health Department. Again, want to thank our board members who are here today, and the ones you all support us so much, and we're always striving to be the best, and you help push us there. So I'm happy to pull anybody back up if anybody has any questions. Mr. Wheeler?
I think he posted my family's work.
Thank you.
Awesome.
Thank you. Yeah.
I got friends in the top of someone in his topic.
Yeah.
Literally, that's been involved since 1970. It's a shot, zero late falling.
Yeah.
And we posted $2.1 billion. I'm going to go sorry, Mr. Robert Thomas, you know, to pod that out of it.
That was good. Yeah, absolutely.
During that time, we also heard intelligence stand up, and governments masked our body, along with the Gates Foundation, Moral Health Organization, and Moral Bust Truth. He fighters about it. Now, until recently, polio was going down about. We were at 99.9% polio free in the world. Has started pneumonia, just as you organized. Starting day, I had a friend who did some sport that at about multi-golf. But locally years, the spurring scene lost all of their vaccine by. Where was that coming? And who did it use?
So the CDC, am I correct, provided immunization money to all the states in the country. And it would go to state health departments, and then they would pass it on to local health departments or other organizations that were working to increase vaccination rates. Before Dr. Spear came to the Vanderburgh County Health Department back in 2014, the Vanderburgh County Health Department never applied for the grant, as Aaron mentioned. Dr. Spear said, no, we want that money. And we applied, and over the 10-year period, received 1.5 last year, over $500,000. And then we were told it's all going away. And so it was the federal funds that were cut, that were given to the state, and have, I'm not going to say it's not stopped our program, but it stopped some of the expansion that we want to continue. We do have additional funding from the state that we're receiving. I think one of the ladies mentioned HFI, Health First Indiana funding, and that has been cut for 2026 and 2027. So we're kind of just having to slow down a little bit on expansion, but you know, we're always looking for other opportunities, other grants, other funding sources that will allow us to continue to provide these resources, especially for the most vulnerable in our community. You know, I think we all understand that we have to provide those services to the most vulnerable in our community to raise all of us up, and that's what's key. So yeah.
I'm just going to pop in here. I'm also the finance chair for the health department board, and I do. Joe says it so much more nicely, which is why we usually let him speak. But we did lose a lot of money from the federal government, and it's going to drastically and dramatically impact the services that the health department is going to be able to provide to the residents of Vanderburgh County this coming year, the years after that. We're doing what we can. I know Joe said that it's going to impact the expansion. I think he's being a little kind. I think for the rest of this year, we're going to be doing the best we can. Next year, we might have to start taking red pens out. And
potentially cutting services. It's on the table. I'm not guaranteeing it, but it's on the table. And a lot of that money not just came from the federal government, but it also came from the state government through the HFI money, Health First Indiana. And so as the finance chair of the health department, I would encourage you to reach out to your state legislators and ask for more funding for public health, because it's having a direct impact on the children of Vanderburgh County. Any other questions on this one? This is Dr. Worley, Dr. Julie Worley. We are so lucky to have her on our board. She is the only pediatric infectious disease doctor in Vanderburgh County in southwestern Indiana. And she is our current board chair, so I'm going to let her talk about that too.
Thank you. I just wanted to say thank you for having us here today to let us, to let us talk about the great work that's being done, and not just with the topics that we discussed, but with so many other services that we provide. And I just, because they won't blow their own horn, I wanted to blow it for them. The Vanderburgh County the Vanderburgh County Health Department is equal to none in the nation. It operates at the highest level. The service that it provides, the outcomes, the Pre-to-3 program nationwide, they've been recognized as having an amazing program. Others are looking at this program to model their own local programs, and we do need to partner with our communities in any way we can. Our community partners to help us, in terms of this shortfall that we're experiencing. We want to continue to grow. We want to continue to help. Other health departments that are very tiny look to us to help support some of their services. And all of that just evaporates when we are just trying to keep our head above water. So we're very passionate about our community and the work that is being done. Joe and the whole health department, every person there, they go above and beyond. They work nights, weekends, they work all the time, and they do everything they can to serve our community. So I just wanted to point that out and tell you that I'm very proud of them, and I count myself lucky that that I'm able to serve on the Board of Health. And we're always looking for new members, people who have passion like us for the health of our community.